Hello, this is Girish. Today I'm going to examine this hip joint. My examination starts both in standing position as well as in lying down position. First, I'll examine in standing position. In standing position, the examination will be from the front, back, as well as sideways. From the front, you need to look for the levels of the anterosuperior spine, the position of the knee, as well as the position of the foot. From the side, can you come this side? From the side, I will see is the position of his spine to look for any kyphosis and any deformities around the hip joint like forward flexion, or in the knee joint to see for any flexion deformities in the knee joint. From the back, I'll see is again his spine, the level of shoulder, the spine, to see for any scoliosis. So, can you lie down please?
Yes, sir.
Examination in lie down position starts with attitude of the limb. So in the attitude, we see for the levels of the iliac anterosuperior spine whether it is elevated or it is downward displacement is or not. Next, the position of the patella. Normally the patella will be facing anterolaterally and the foot will be plantar flexed, usually around 15 degrees of plantar flexion. That is the position of the ease in most of the patients. So coming to the local examination around the hip joint, first we see for the color of the skin, any signs of chronic inflammations like sinuses, scars, or any discharging wounds to develop any infections. So, and next, the palpation. The palpation of the joint starts with to see for the local temperature, on the anterior aspect as well as the lateral and the posterior aspect. To see for the local temperature. Next comes the tenderness. The tenderness, we need to elicit the tenderness around the bony joint as well as bony prominences as well as the soft tissue structures. The bony prominences are anterosuperior spine. To palpate the anterosuperior spine, we need to palpate the previous symphysis and go around walk along the inguinal ligament and the first bony prominence which is felt is the anterosuperior spine. See for any tenderness in the anterosuperior spine. Then anterior hip joint line. Anterior hip joint line lies in between the 1 centimeter below the mid-inguinal point. See for any tenderness in the anterior joint line. Next comes the palpation of the trochanter. In the palpation of the trochanter, there are 4 things you need to know about it. One is the any local temperature to rule out any infection. The second thing is the tenderness. The tenderness, to palpate the tenderness, the trochanter, the limb is little bit interrotated and so that the trochanter is prominent. Feel for the tenderness in the trochanter. Next, see for the surface of the trochanter. If normally the surface of the trochanter is smooth, in cases of infection or in cases of any traumatic fractures of the trochanter fractures, there will be a roughened trochanter. And also see for any thickening or broadening of the trochanter, and also the eye lining trochanter. When it is compared with the opposite side, if the trochanter is moved upwards, it's an eye lining. Next, coming to the movements of the hip. The movements of the hip, they are mainly the 4 movements: the flexion, extension, abduction, and adduction. And also there is one more, the combination of all these things includes the circumduction. The movements of the hip should first, there are 4 movements mainly: the flexion, extension, abduction, and adduction. To elicit the flexion, the anterosuperior spine is stabilized and the knee and hip is flexed. So this is the amount of flexion. So there is a complete flexion. The next is extension. To elicit the extension, make the patient prone. Can you turn around? So to elicit the extension, fix the pelvis and try to lift the thigh. This is about 15 degrees of extension is present. Can you turn around? So my question once again. To elicit the rotations of the hip, there are 2 different methods of examining the rotation. One is the log roll test, where you just rotate the limb in extension. The second one is the flexing the hip and knee joint to 90 degrees and rotating and turning towards one side. This is internal rotation. Where the other, when you cross over the other limb, then that is external rotation. So normally there is around 30 to 40 degrees of internal rotation and 50 to 60 degrees of external rotation. To know the abduction, again the pelvis is fixed, the anterior superior leg spine is fixed, and one eye should concentrate on the other anterior superior leg spine and try to abduct the hip joint. This is the amount of abduction percent. This is about 60 degrees. When the limb crosses towards the other side, then that is adduction. It's around 30 degrees. Normally it should cross about the proximal aspect of the leg. So that's a normal amount of abduction percent. Now there are some tests in eliciting the in disease of the hip joint. One is the fixed flexion deformity. The fixed flexion deformity, whenever there is conditions like infectious disease of the hip joint or any injury causing stiffness of the hip joint, where there is a compensatory mechanism takes place, where the hip goes for flexion and the spine goes for scoliosis, kyphosis. So to elicit that one, the hand should be insinuated underneath the lumbar spine and see for any arching of the lumbar spine. And with the hand placed underneath the lumbar spine, flex the normal limb till the lordosis obliterates. Can you hold this one? Hold in both hands. So suppose if there is a fixed flexion deformity, this knee joint flexes. So this is the amount of the angle between the leg and the couch gives the amount of fixed flexion deformity. Can you straighten this one? This is Thomas test. In cases of abduction and adduction deformity, the anterior superior leg spine levels are noted. In cases of adduction deformity, the level of the anterior superior leg spine will be at a lower level, so that there is apparent lengthening. So cut. Abduction or adduction deformity. For in abduction deformity, the anterior superior leg spine is at a lower level. So that is very difficult to demonstrate. Just I'll show how we do the correction of the squaring of the pelvis to correct the abduction deformity. Suppose the anterior superior leg spine is at the lower level and the limb is there is apparent lengthening. To make the anterior superior leg spine at the same level, that is called squaring of the pelvis, abduct the affected limb. If the anterior superior leg spine comes at the same level at this angle, and this is amount of abduction deformity present. The same thing when there is adduction deformity, the anterior superior leg spine is at an higher level. So you need to adduct the limb till the anterior superior leg spine comes to the same level. So that is the amount of adduction deformity present. Stop. Now coming to the measurement of the limb. The measurement of the limb, first we need to measure the apparent length and the true length of the limb. So the length may vary in different conditions, like whether there is a fracture or whether there is a limb affected due to some other pathological conditions, like dislocation of hip or any fractures can cause the limb length discrepancies. So one is the apparent length. Apparent length, we take the measurement from the Ziffy sternum to the tip of the medial malleolus. So this is apparent length. To measure the true length, we need to square the pelvis. As I said earlier, if there is a deformity, the adduction or abduction deformity, we need to square the pelvis so that the anterior superior leg spine are at the same level. So to measure the true length, the measurement is taken from the anterior superior leg spine to the medial joint line, from the medial joint line to medial malleolus. This gives the true length. So suppose in cases where there is a shortening of the limb, we need to compare with the opposite side. Suppose say there is a shortening about 2 centimeters. So now we need to know where the shortening is, whether it is supratrochanteric or infratrochanteric. To know this, we need to do a certain test, like one is to draw a branch triangle. So the branch triangle, and I'll show you this one. I'll show with my fingers. To draw a branch triangle, we need to palpate the anterior superior leg spine. From the anterior superior leg spine, palpate for the tip of the deltoid trochanter. So draw a line between the anterior superior leg spine to the tip of the deltoid trochanter, and other line from the drop a perpendicular line from the anterior superior leg spine. Connect these two lines. So the base of the triangle gives the amount of lengthening. Compare with the opposite side. If there is shortening, that indicates it is supratrochanteric shortening. So other tests, other measurements, like you can measure one is bitrochanteric test, where you measure. It's very difficult to assess in this one since the patient is covered up. So the Morris bitrochanteric test, Schumacher's line, all this gives the information about the supratrochanteric or infratrochanteric shortening. Now coming to stop. This is about hip joint examination. Now other joints needs to be examined. One is the sacroiliac joint. In sacroiliac joint pathologies, it may mimic pathologies of disc lesions like sciatica. First we need to know about the straight leg raising test. Ask the patient to raise the leg, see for any pain along the posterior aspect of the thigh. That is a stretch test, sciatic stretch test. So if there is pain, the pain can be coming from the sacroiliac joint or from the lumbar spines. To know the pathologies, so one is you need to do a Faber's test or a Patrick's test, where you flex the hip joint and the knee joint and externate, and the pressure is applied on the opposite side. Suppose if the patient has got pain in the sacroiliac joint, he winces. So this is how we demonstrate the Patrick's test. The second thing is the Pompandel test. Pompandel test is, again this is for sacroiliac joint. Flex the hip joint, knee joint and adduct the hip joint. After adducting, give a thump along the knee joint, along the axis of the femur. So if the patient has got sacroiliac pathology or sacroiliac instability, the patient will experience a pain. The next is the Jensen's test. In demonstrating the Jensen's test, ask the patient to come to the edge of the couch. Can come to the edge, and the affected limb is dropped down. Affected limb is dropped down, and the normal limb is flexed. Suppose if this gives a rotational stress to the sacroiliac joint. If the patient has got pain in the pathology in the sacroiliac joint, the patient will experience the pain. Now next is other test is Fidus test. Fidus test is to know the acetabulo-femoral impingement, wherein the hip is flexed and interrotated and adducted. If there is a femoral acetabular impingement, the patient will experience pain. In examination of the groin, we need to know about any tenderness along the insertion of iliopsoas, where palpate with the pathology. The patient will have tenderness along the iliopsoas tendon and the proximal in the groin region. So just see for any tenderness in the sacroiliac region, and also you can stress the iliopsoas by extending. If the patient has got iliopsoas tendinitis, the patient will experience pain. And feel for any hamstring tendinitis or by palpating the medial aspect of the thigh. So this is about the examination of the hip joint. Other special tests are there. One is now I would like to do some special tests in standing position. One is a Tenenberg test. Tenenberg test asks the patient to stand on the normal limb first. Can you stand like this on a normal limb? So you can examine the patient from the front or from the back also. When you examine the front, you need to see for the level of the anterosacroiliac spine. When the patient stands on the normal limb, the anterosacroiliac spine droops down. On the normal, the anterosacroiliac spine remains the same. Whereas when the patient stands on this is the affected limb. They say this is your right affected limb. Can you stand on this? So when the patient stands on the affected limb, the pelvis drops down like this. So what is the Tenenberg test? Tenenberg test is to know the abductor mechanism of the hip joint. To know the abductor mechanism of the hip joint, first ask the patient to stand on the normal limb, and the affected limb should be lifted up. So while doing this test, you need to see the anterosacroiliac spine or the gluteal folds from the back. So since I am standing from the front, I will be looking for the level of the anterosacroiliac spine. In the normal limb, when the patient stands on the normal limb, the affected anterosacroiliac spine is elevated. So that is a normal mechanism where the abductus pulls the pelvis downwards, so that the opposite anterosacroiliac spine is elevated. And it is very difficult to demonstrate in a normal individual. So then ask the patient to stand on the affected limb. When the patient stands on the affected limb, the anterior leg spine droops down to the normal side. So that indicates the failure of the abductor mechanism. That is Trendelenburg test. The next test is the gait. You need to assess the gait of the patient. Without assessing the gait, the hip examination is incomplete. So there are different types of gait. One is the antalgic gait. Can you walk with an antalgic gait? The stance faces very short in antalgic gait. The next, can you go back? The next is the eye-stepping gait, where to clear the ground, the patient tries to lift the leg and then place it like this. So that is eye-stepping gait. The next is Trendelenburg test. The patient droops towards one side. Can you walk like this? Drooping on towards one side. This is Trendelenburg gait, where the patient droops towards one side. The next is circumduction gait. The circumduction gait is to clear when there is a fixed or the ankylosed hip. The patient tries to circumduct the hip and then walks like this. This is circumduction gait. So this ends my clinical examination of the hip joint. Thank you.